Rectal, upper GI, and bariatrics. This new addition demonstrates our commitment to be able to offer the latest medical technology for the benefits of our patients. We are proud to introduce to you the Da Vinci XR. So what I'm going to do next is just give you some slides presentation on the application of the Da Vinci robotics in the management of gynecological cancers. Now, this is one aspect where we use the Da Vinci robot. Okay, this is in the management of endometrial cancer. As you all know, there are different types of gynecological malignancies. You have cancer of the uterus or endometrial cancer, you have cervical cancer, you have ovarian cancer, and of course vulva and vagina cancer. But one area where the Da Vinci robotics is extremely important is in the management of endometrial cancer. So I'm not sure how many of you are aware of the concept of sentinel nodes. Okay, usually when we treat endometrial cancer cases, what we used to do is to remove all of the lymph nodes inside the abdomen, the pelvis. But with the Da Vinci robotics, we can remove 1 or 2 lymph nodes that will represent the whole group of lymph nodes. And that's what we call sentinel lymph nodes. The advantage of that is you don't have to remove all of the lymph nodes and you reduce the morbidity to the patient. Okay, and that's the concept of sentinel lymphadenectomy in endometrial cancer management. So endometrial cancer is a worldwide problem. You can see globally you have over 400,000 cases every year. In the UAE, we have about 130 cases yearly, and one of the risk factors for endometrial cancer is obesity. And these patients, they require comprehensive surgical staging, and that surgical staging will involve removing pelvic lymph nodes. And achieving full surgical staging in morbidly obese women could be extremely difficult. And this is where the robot is extremely important. So I've talked to you about what is called the sentinel lymph node. The sentinel lymph node is the first nodes of cancer spread. Some people also refer to it as the echelon lymph nodes. It helps to determine the extent of spread in helping to guide management. If you do, you can do a full lymphadenectomy or you do sentinel lymph nodes. And if the sentinel lymph nodes is positive, then you can assume that the other lymph nodes may be involved, in which case the patient will require additional treatment in the form of radiotherapy or chemotherapy or both. So if you look at this diagram, this one shows mainly in the pelvis, the lower part of the pelvis. You can see most of the lymph nodes are situated in the pelvis. And that is where you can focus the Da Vinci robotics in taking your sentinel lymph node. Most of the sentinel lymph nodes you will find around here. So you don't have to go high up in the abdomen looking for them. And this is just another diagram showing what you find. And when you do it, you inject a certain dye into the cervix, and you can see the green dye. And this is what you see. And once you can identify this green dye, then you can look for the sentinel, just go directly and remove the affected nodes instead of removing the whole of the pelvic lymph nodes. Now, the benefits of sentinel lymph nodes instead of full lymphadenectomy is that you can have a quicker post-operative recovery, and you have less risk of the patient developing lymphedema. Lymphedema means you have bilateral swollen lower limbs. So if you just remove a single lymph node instead of removing all of the lymph nodes, then that risk is not there. So these are just some of the various trials looking at whether sentinel lymph nodes is oncologically safe. And we have some statements from NCCN and from ESMO. These are bodies that actually regulate how cancer can be managed. And they've all concluded that it's perfectly safe to do sentinel lymph nodes in women who have endometrial cancer. So robotic ICG sentinel lymph nodes, what are the indications? If you have a patient with endometrial cancer and they've had imaging, especially PET-CT, and it shows there's no involved lymph nodes, okay? And if there's no imaging evidence of extrauterine disease, and then you can go ahead and do your sentinel lymphadenectomy. A few exclusions are a kind of cancer we call uterine sarcoma. So usually when we have a patient with endometrial cancer, we discuss all of them. All of our cancer cases are discussed in an MDT, or the multidisciplinarity meeting, where you have a group of surgeons, you have the medical oncologists, you have radiation oncologists, and you have the pathologists and the radiologists. So we discuss every patient. So you don't have a single person making a decision about a patient. So it's a group decision. So once we've all decided that the patient is suitable for the procedure, then the surgeon can go ahead and do the procedure. So we had a classical case, a patient who is 37 years old, no children, and does not have any wish to have children, with a BMI of 52. The normal BMI is usually about 25. Was diagnosed with endometrial cancer. Preoperative MRI suggested there was invasion into the muscle of the uterus. So the patient was very keen to preserve her ovaries, and she was discussed in the MDT. So with the help of the Da Vinci robotics, we were able to do her surgery. We were even able to do sentinel lymph nodes. Without the robot, it's virtually infeasible to do lymphadenectomy in a patient with such a high BMI. And the patient was able to go home the following day after surgery. So thank you very much. And if there are any questions, I think what we're going to do, I'm going to call on my colleagues to introduce themselves again and then tell you what they do with Da Vinci robotics. Thank you.
Would you open the mic?
Okay. Yeah.
Are you going to go up on stage?
Do you have, no, you're not supposed to show. You don't have slides.
Well, if you've got any questions, do raise your hands, and then I'll bring the microphone over to you. But we'll proceed with the introductions.
Yeah, thank you, Dr. Jaff. So again, my name is Dr. Rehan Saif. Part of what I do is HPB surgery, so that's liver and pancreatic surgery, in addition to liver and kidney transplant. So I know this is a session about robotic surgery in general. You know, a lot of my colleagues, all of us who do robotic surgery, the theme is that, you know, the advantage that the robotic platform gives us, that it's able to offer minimal access surgery to more patients. So when you talk about what I do for liver and pancreatic surgery and also transplant, traditionally this has been one of the specialities that has never taken off on the minimal access route. We were the last to take off because of obviously the technical challenges. So there are not many centers that would do all types of liver and pancreatic surgery by the traditional minimal access route, which is laparoscopic surgery. Whereas what the Da Vinci robotic platform offers us is that we're able to offer this to a lot more patients. So in addition to complex liver surgery, complex biliary and pancreatic surgery, and also a lot of cancers which are multi-quadrant, for example, colon cancer that has spread to the liver, who would traditionally require 2 separate procedures. It would be very difficult to do it if we did not have the XI platform. So this offers us to do minimal access surgery in multiple quadrants of the abdomen. So a lot of patients have combined colon and liver resection, combined rectal and liver resections. So that's possible using the Da Vinci robot. And one of the reasons why laparoscopic surgery is not practiced in many centers for this particular specialty is because of the challenges in the reconstruction after resection. For example, when you're doing a pancreatic resection or a biliary resection, it requires a biliary anastomosis, a pancreatic anastomosis. There are not very many skilled surgeons who can do this laparoscopically, and your cases have to be carefully selected. Whereas with the robot, doing the anastomosis is a lot easier. So we're able to offer this to a lot more patients. And like Dr. Jaff mentioned, one of the biggest advantages is in patients who have a high BMI, who are obese. Doing any kind of minimal access surgery in them is extremely difficult, but whereas the robot, this is where you see the main advantage. A lot of problems that these patients face is the morbidity because of their wound, because they're obese. You know, you have a big wound. This is what delays the discharge from hospital. So basically, we are able to offer this to a lot more patients. And also these days, you know, most of when we talk about transplant, which is part of what I do, all the donor surgeries these days, the standard is minimal access. We used to do big open cuts, and this is one of the main reasons, because you have to remember that a lot of the donors are young patients. Majority of them young females who are still unmarried, who are donating to their brother or their loved ones. So this is one of the tools that we use where they can have a much better quality of life afterwards. So I don't know if any of you have any questions specifically to what I do, but I'll pass on to my other colleagues, Dr. Picasso and Dr. Rishi, who can tell you about the other applications of the Da Vinci robot. Thank you.
Hi, good afternoon everybody. Again, let me introduce myself. I'm Dr. Picasso. I'm the head of the Department of General Surgery and Surgical Oncology at Burjil Medical City. Thanks to Dr. Jaff because he has introduced important features of the robotic technology. And also Dr. Rehan has underscored important aspects for complex surgery. Let me give you my hints about what robotic surgery can represent for the scope of general surgery and surgical oncology. And first of all, I would like to highlight that in many places all over the world where the robotic programs are well established, general surgery patients comprise the big bulk of numbers. That means that the robotic platform from general surgery is completely outstanding. Let's think about why. Because we can wonder, okay, you can do a cholecystectomy, you can do a inguinal hernia. We know that the inguinal hernia is the most common surgical procedure, elective surgical procedure worldwide. So do we need to spend money on the robotic platform for doing a hernia? It's under debate nowadays. What happened? What happened is that most of us are quite senior. We would like to be younger, but we are senior. We've done plenty of cases by laparoscopy, and I can give you my humble opinion in the transition from open to laparoscopic to robotic. We are starting in our hospital a few months ago. Now we are surpassing more than 200 cases of robotics. We are the number one, I think, in Abu Dhabi because of the speed of implementation of robotics. I can give you my opinion, is that the aggressiveness, the trauma to the patient, no matter you are doing a simple inguinal hernia, with the robot is practically zero. It's faster, the manipulation, we don't need to use special tackers. You can stitch inside like if you were your hands inside the body. So what happens that in our hospital we are doing 99.0% of cases of abdominal wall surgery as day case. The patient may leave the hospital, are leaving the hospital the same day, 2 or 3 hours after the operation. No matter we are doing a recurrent or multi-recurrent hernia, or we are doing a ventral hernia. Let's speak about ventral hernias. I don't know if any surgeon here, apart from us. General? Bariatric, so, but you are general. Good. So we can say there are certain operations of abdominal wall surgery that simply cannot be done by laparoscopy. When we are trying to stitch, for instance, a patient with a ventral hernia with a rectus abdominis diastasis, a rectus divarication, you are suffering doing by laparoscopy, or maybe you will not enter to do it anymore in your life. I tried in my life a couple of times and I deter myself. With the robot is another story. So I'm just giving these details because for general surgery, I think that in the future there will not be laparoscopy anymore. Once the costs of robotics they go down, there will be the disappearance of laparoscopy. I think it's quite clear. It happened the same with laparoscopy when we started. I remember starting from open to laparoscopy. What is this? This is so complicated, so costly, and now there is no open surgery anymore. When was your last time you did an open cholecystectomy? You cannot remember, like me. So that being said, and give me some minutes to speak about surgical oncology. Surgical oncology is a totally different story. I do think that if we are having a robotic platform in our hospital and we have a trained surgeon capable to proceed for surgery, the surgery should be done robotically. The advantage of lymph node dissection, the advantage of a clean operating fields dissection to do the proper technique as we should be doing by open can be achieved by robotics. We are doing in our hospital complex cases, reoperative cases with a ultra low resection of the colon. Also, not to say about the esophagus. Now the esophagus, doing an esophagectomy with the robot is not a piece of cake, but it's much simpler. We are doing thoracoscopic procedures as well. And of course, Dr. Rehan is doing liver, pancreatic, we are doing spleen, we are doing even retroperitoneal. We did some cases of pericaval, periaortic lymph node dissections with the robot. And this is a different story. So in summary, I think that the robot is here to stay. In some places it's long time, it's the past. So if anybody wants to push for the future, the only way is the robot. We are in Burjil Medical City for anybody who wants to make any consultation, any training, even any training. We're more than happy to have you with us around. Thank you so much. Thank you. Any question?
I've got a microphone for you here.
Good afternoon, Doctor. It's really nice to hear the advances you shared. I'm a cancer supportive care physician. One of the challenges really we have is esophageal cancer. So right now, our center in Singapore and Philippines, we compress the right lung and then access it there. But are there advances in robotic surgery as well that can do esophageal resection even better, as you mentioned?
Yes, of course. You know that for the esophagus there are many options. Many. I think as many surgeons, we can do, people now with the robot, you can do a trans-hiatal section to do only 2 access from the abdomen and the neck. But if you want to do, you are more Lewis Tanner or like with the previous right thoracotomy, and you want to do a minimally invasive thoracoscopy, you can do both by robotic laparoscopy and thoracoscopy. Our preference is to do all full the abdominal time laparoscopically, robotically, and maybe small incision assistance for the stapler if we do a intrathoracic anastomosis. But you know, if you want, for instance, some other colleagues, they are doing a cervical anastomosis, and they do all with robotic. Abdominal robotic, gastrolysis, robotic thoracoscopy for esophageal lysis, and only cervical incision with anastomosis. No incision at all, only at the neck. It depends on what is your choice for the anastomosis. What is your choice? Cervical or thoracic? You are Ivor Lewis or you are Oringer supporter?
I think the recent literature was showing cervical would be easier. In your opinion, would that be similar?
No, I mean that both techniques are perfect. Here the advantage is that you can use the robot for whatsoever you want to. Okay? Thank you so much for your nice question.
Excellent. Now we're going to get Dr. Rishikesh to talk to us about robotics in urology. As you all know, I think we should actually have more men here because robotics in prostate surgery is amazing. And the robot is actually meant for prostate surgery. So I think we can hopefully get more men to come here once Dr. Rishikesh starts talking.
I can see no men here. So the few men and the more ladies who are here, I will ask two technical questions to very less number of people. These people are not supposed to answer. So two differences, just technically, between laparoscopic instrumentation and robotic instrumentation. What do you think is the difference between a laparoscopic instrument and a robotic instrument once it is placed for a dissection? Any guess, any idea? Okay, so is there a guess of what is the level of magnification when you do laparoscopy? So just a simple laparoscopy, 4 to 5 times magnification. In the XI system, it is 3-dimensional view and 10 times magnification. So you can see how precise we can get to operate. So I gave you the answer for the first question. Now, second, any idea about an instrument which is, so any open instrument, scissors, does the scissor bend? It is straight. It just cuts. A needle holder, does it bend? It doesn't bend, it is straight. In laparoscopy, it is still the same. The scissor will always remain straight. It is linear. You can move it this way. You can move it this way. In robotic, the interesting addition is endo wrist. When I call the endo wrist, so imagine my hand had no wrist. What will my hand do? It will move at the shoulder, it will move at the elbow, and if I have to do something, I am doing this. Right? But if I want to do this, can my laparoscopic instrument do this? No. Can my open instrument do this? No. This is the advantage of the robotic instrumentation, where it is called endo wrist, which means I can go in and then turn my scissors to this angle and then cut, this angle and then cut. Not only this, I can do this and cut. I can go this way. The third advantage of robotics is that it doesn't identify my left hand and the right hand. So my dexterity, if I am a right hand dominant person, I can still do very good with my left hand, which is not true in all situations. So these are certain small nuances as to why the robotic surgery is more easier, more precise in a very small cavity. So where I operate, or where Dr. Jaff operates, is right deep down into the pelvis. When we remove the prostate, it's a very small place. It is like 3 to 4 centimeters, and we have to do the anastomosis. So not only the magnification, the endo wrist, this is what helps. And when he brought up the topic of men and prostatectomy, so it is one of the best implemented surgeries as robotic prostatectomy for cancer of the prostate. For multiple reasons, the blood loss is less, the anastomosis is very good, and 5-star marks, full marks for a good surgeon to be able to do nerve sparing prostatectomy, which means that the patient can recover the erectile function, the sexual function after the prostate surgery. So this is about the robotic and the urology. So I'm sure there are not many questions because I questioned and I answered myself. Thank you so much.
Do we have any questions for us? You must have questions about the robot.
If you've got any questions, I've got a microphone here in the audience.
Now, the robot obviously is extremely beneficial to the patient. Now, one of the things that we as surgeons do when we're doing laparoscopic surgery is to blow up the abdomen, especially if you're working the abdominal cavity or in the pelvis, you blow up the abdomen with gas. Okay, you blow up the abdomen with gas, and you have to operate at a high pressure to be able to see everything. Okay, with the robot, you don't need so much pressure, because what happens when you use so much pressure to operate is that the patients end up with so much post-operative pain. So many patients who have had laparoscopic surgery will have shoulder tip pain, and that's because the amount of pressure you use is very high. With robotic surgery, you don't have to go that high up, and the patients recover so much quicker. And can you imagine when you're operating, you're seeing everything magnified and it's in 3D. And as a surgeon, you don't have to rely on an assistant to control your camera, to control your instrument. You're in control of everything. You know, everything is under your control. So it's a dream for the surgeon to be able to operate with a robot. And the comfort of the surgeon will transform into the patient having better surgery and quicker recovery. I'll tell you a very, very short story. I've been a consultant for a long time. If I tell you how many years I've been a consultant, you'll probably begin to guess my age. So I'm not going to tell you how long, okay? But what happened was that in 2017, I needed shoulder surgery, because most of the patients I operate on are women who have very high BMI. BMI in excess of 50. Sometimes BMI as high as 60 or 70. So over a period of time, that will have a toll over your body. So in 2017, I had shoulder surgery, and this was back in the UK. And that was when I said, look, I need to start doing robotic surgery if I'm going to prolong my life as a surgeon. And I had surgery, and I was told that you're not supposed to operate. Don't do anything after 6 weeks. After 2 weeks, I was bored at home. So I went to Europe. I went to learn how to do robotic surgery. Exactly 4 weeks after my operation, I was sitting on the console doing the first hysterectomy with the robot. And the rest is history. So it's beneficial for the surgeon, and it's beneficial for the patient as well.
Any more questions, guys? I guess we can wrap it up then. If you've got any questions, you can always approach the panelists directly as well. That brings us to the end of the session. Thank you, Dr. Jaffar, and thank you to the panelists for such an insightful discussion today. A reminder to all of you that you can find out more information about Burjeel Medical City and registering your interest by scanning the QR code